Now, we moving on to the next speaker. He is a very dear friend of mine, and for the first few years when we were discussing each other, we used to have a lot of arguments where I used to question his entire field, because I came from institute where they were doing intraoperative neuromonitoring, and my outlook on IONM was very poor, that it doesn't help. And in the first few years, we had so much of argument, and then he started showing his results and his work spoke, and now I'm totally on the other side of the argument now. I mean, this is how we treat our, we call him professor, because once he starts speaking, you know that there is some depth in it whenever he is giving some conclusion to any argument. So without wasting any time, I call my dear friend Nishanth. He is someone who is doing the work behind the curtains. You will not know the extraordinary work which he does, and his field, transcends many specialities, and it is giving us good outcome in our surgical results. So Nishanth, please.
Okay, thank you, Vishwa, for a very nice introduction. So this is the schema of my presentation. I'll just talk about what neuromonitoring is. It's a specialized field, and we are into the field that we actually need to take some time to actually explain it to specialists who are not exposed to this particular specialty, because this is a very upcoming specialty. And we also do some work outside the operating theater. So before I get into it, I'm sure there are many specialists who have spoken with me informally as to what is a physiologist doing inside a laboratory, inside an operating theater, and that too in a private hospital. So before I answer that question, I wanted to explain or show some examples where experimental physiology has really made paradigm shift in the clinical practice. So baroreceptors. So baroreceptors, do they respond to pressure or do they respond to stretch? Any takers?
Suggest pressure.
Pressure? No, they are actually stretch receptors. Okay. So how was this found? So how can we actually prove that baroreceptors respond to stretch and not pressure? So who does this? So who actually makes these conclusions? So experimental physiology. So how did they find out it was actually a stretch receptor? Carotid sinus is there. They pick up afferent information to the brainstem. So they put a plaster of Paris cast around the carotid sinus that prevented it from stretching, and then measured the neural response. So if the pressure was raised with a plaster of Paris around the carotid sinus, there was no baroreceptor activation. So what it means is that the carotid sinus has to actually stretch to actually bring about the baroreceptor reflex. So these kind of first principles or basics are answered with solid evidence from science. So you need to carry out. And you cannot outsource it to someone who's not a doctor, right? So these are all done by doctors who are very passionate into certain concepts, and then they are tried out on animals and then translated onto humans, right? So another outrageous experiment. This was by Sergey, and this was the first experiment that actually showed that heart is not necessary for the survival. He actually did a series of experiments called revival experiments, where he severed the dog's head and then used the first artificial heart-lung machine. I mean, it is the predecessor to the current heart-lung machine. And they tried out different experiments like response to various stimuli. You put some water droplet onto the tongue, it starts leaking. So it it shows all the characteristics of life even after severing the head. So as long as you maintain the oxygen supply through blood, then the head survives. So this gave the concept of organ transplantation and heart lung missions. So another example is Banting and Bess discovery of insulin. That's the dog which they pancreatized to actually extract insulin, and they showed that insulin was indeed, I mean, prior to this, diabetes management was all starving diet. They didn't know insulin deficiency was the cause of diabetes. So they proved it, and then insulin therapy, revolutionized how diabetes was managed. So these are paradigm shifting experimental revelations which changed clinical practice. Now, electrophysiology, the point is to draw parallel as to how intraoperative neuromonitoring can change a neurosurgical perspective. So, as Vishwa said, he was of the view that neuromonitoring was not of much use. And even presently, if you go outside SIMS, talk to any neurosurgeon, even experienced, they will say that neuromonitoring is not of much use. And that was the same scenario back in AIMS, where a lot of senior specialists were not really doing monitoring. They're used to their own anatomical way of, predicting, and then if something happens, it happens. So they a priori explain and that complications are usual, and then they accept those complications in those kind of surgeries. So electrophysiology, the field, so electricity is basically the basis of life. This was first shown by Miller-Urey experiment, where he put all the ancient earth materials, and he tried to create life out of chemicals. So he just added, nothing happened, but something happened only after he passed electricity. So the hypothesis is that lightning would have hit the earth when there was no life, and then that started producing chain reactions and some chemicals, and they all got together and formed the first life. So with respect to electrophysiology, the Luigi Galvani, an Italian physiologist, is considered as the father of electrophysiology. He was working with frog nerve muscle preparations, and it was serendipity that when lightning hit, one of his preparations started twitching. So that's how they got the first idea that it's actually electricity that's making us move. Prior to that, it was all vital spirit theory and all those kind of spooky stuffs that they believed in. So along similar line, Galvani's own nephew, Aldini, carried on his legacy and passed electricity onto fresh corpses and carcasses. They were so passionate that they went to the place where they guillotine, and they got the fresh dead bodies and used their own devices to pass electric current. And even in dead bodies, when they passed electric current, they showed, signs of life, like movement. I mean, it's not true sign of life, but they started moving. So that showed that electricity is causing us to move. So what is the basis? The basis is that all cells have a resting membrane potential, but there are specialized cells which, upon giving specific stimuli, can change these potentials to result in an action potential. So they are excitable tissues. The excitable tissues are the nerves and muscles. So the first ionic basis theory for action potential was given by Hodgkin and Huxley. So we don't have to get into the details. So physiology, it's the trend word we always hear in the conferences, and even as Dr. Sishu was speaking, he mentioned physiology. But where are physiologists? You don't see them. And I wanted to emphasize on this because such structured departments exist only in central institutes, and outside the central institutes in a private setup, a physiology department is run for the sake of MCA inspection. It's quite unfortunate, but that's how it is. And they are usually considered as teachers. But as such, physiology has to be done in a particular way. In fact, a physiologist has a role in each and every clinical department. I'm sure you will all agree, and you can, think of examples where they've made, path-breaking contributions like infertility. A lot of work is physiology only. So this field, intraoperative neuromonitoring, is considered as a subspecialty of clinical neurophysiology, which is an established specialty in the West. So in US and UK, clinical neurophysiology is a separate subspecialty, which means you don't just stop with your clinical neurology training. You have to actually take a separate fellowship course to do clinical neurophysiology. So you need to have both the bigger picture in your mind, and you also need to have an eye for the details. And there are subspecialties like clinical neurodiagnostics and sleep testing and autonomic testing and intraoperative neuromonitoring. So all these modalities of intraop neuromonitoring are considered as an extension of clinical examination. So first we need to understand what the patient is having and what the surgeon is expecting, and we need to use modalities to answer specific questions during surgery. So why do we do it? So it's basically like doing a neurological examination in the OT when the patient is anesthetized. So if I want to make sure that a patient's hand is working, or leg is working, or cranial nerves are working, then I can always ask the patient to do in the OPD, like move, or I can assess the sensation. But when the patient is anesthetized, what can I do? I can't make the patient to, I can't give them instructions. So we need to kind of tap into their nervous system. So that's where electrophysiology comes into play. So we tap these signals, and we serially monitor these signals, making sure that they don't get distorted by other factors, extraneous factors. So the goal of neuromonitoring is to maintain that fine balance between maximal surgical intervention while minimizing neurological injury. So in case of tumor resection, maximal resection or complete resection is the ideal goal. And in case of deformity corrections like scoliosis surgery, we want a perfect spine. So we should do it without compromising the neurological function. So it's basically use of electrophysiological methods to monitor the integrity of neural structures during surgery, and provides real-time feedback to the operating surgeons as to what's happening, so that if there is a problem, true problem, they can do course correction. And it's now considered standard of care in high-risk brain, spine, peripheral nerve surgeries across many specialized hospitals in the West. So I won't say it is standard of care across the West, because even there is paucity of physiologists, and not all centers do. But whichever centers do, they are like centers of excellence. So what is the principle or the central tenet of neuromonitoring? So whenever there is an injury, we assume that, or whenever there is a graded injury, we assume that the stages of injury go through like this. First is the stage of electrical failure, which is what we pick up during our intraoperative neuromonitoring studies. And then if it is unchecked, goes into a stage of reversible cell injury, which if unchecked or progresses, it goes into stage of permanent neurological injury. So the idea is to detect injuries at early stage of electrical failure, so that you do something so that they don't progress to stage of permanent neuronal injury. So you serially assess functions, that's called monitoring. We can also help surgeons to identify structures, whether it's a motor nerve, whether it's a sensory nerve, whether it's motor cortex, or sensory cortex. Identification of neural structures can be done electrophysiologically, and it's considered as gold standard. This may come as a shock because we often think that what surgeon says is correct, but only when you work with the closely with the team, you actually get into the layers with the surgeons that they actually come out and say, yeah, I got stumped today. I thought it was motor cortex, but it was not motor. We thought it was a nerve, but it was not a nerve. So these kind of critical inferences we make during during surgeries, and it's not enough for me to say this is what it is and then go. So the proof is in the pudding. So it has to be correct, and they look at the post-operative outcomes, and then they kind of ensure that or verify that what I predict is the same. And it's also useful in identifying new tracks or attributing functions to newly identified structures. So this has been our work so far. We do about 250 cases a year, and not just one type of surgery, diverse kind of surgeries, cranial, CV junction, spine. We also have orthopedic team collaborating with us. We have ENT team collaborating with us, and we have tried to, use IONM for CTVS surgeries also, but there is lack of equipment, lack of person. Another person is needed to do that. So one of the most important or major milestone in the evolution of intraoperative neuromonitoring is the collaboration between Penfield and Jasper. So it was their pioneering work that gave the concept of motor homunculus. Homunculus basically means a little man. So they could map the entire body onto specific structures of the brain. So that was the first time that they showed that the parts of the body are organized onto specific parts of the brain. So in our case, it was essentially the passion of Dr. Suresh Babu, who wanted to establish it as regular intervention in all his surgeries. So without a surgeon wanting this, whatever we did could not have happened. So Suresh Babu sir was always primed and always wanted to have neuromonitoring. And as soon as I finished a bit of training in AIIMS Delhi, I came here, and then I kind of fine-tuned a lot of modalities which I was not practicing even in AIIMS. Even current date, AIIMS Delhi has not started some of the things that we are doing currently. Sir, you will be putting it on YouTube, no? Anyway. So many non-neuro yeah. Many non-neurophysiologists consider IONM to be a straightforward tool. They think that as, okay, you use neuromonitoring and the surgical results has to improve. That's not the case, because many studies have shown that neuromonitoring is a complex intervention. What it means is that it's not just the use of intraoperative monitoring. There are other factors at play, like surgeons' expertise with respect to a particular, surgery. So in the hands of experienced surgeon, neuromonitoring even enhances the outcome. The prior institutional experience, who's doing intraoperative monitoring, and what is the surgeon doing upon raising an alert, and various patient characteristics. So it's not necessary that you use intraop monitoring on a single case and over the course of time your results will improve. So you have to use it consistently, learn little nuances as to how you can improve your surgical technique, and then the results start showing. So this is what I said. So electrophysiology's genius is that we can tap into the nervous system. So we use special devices to actually pick up very small potential differences, and then we try to decode what's happening in the nervous system. But the problem is that these devices pick up all the voltage fluctuations, not necessarily only from the tissue or the structure that we want or the structure of interest. So to put it into perspective, you know, it is similar to picking up the noise of a pin drop from when a rock band is playing with multiple speakers. So if you look at the amplitudes, so EMG is about 3 millivolt, the brainstem auditory evoked potential is about 0.5 microvolt, whereas the electrocautery artifact will be 100 millivolts. So we have to pick up a very small signal from the background noise. So that's the most challenging thing. And now there are more surgeons who are deciding to use new teams. So in their algorithm they can use this. So when to perform IONM? So based on inherent surgical risk, if the literature says the chance of injury to a particular neural structure is more, then we can start considering use of neuromonitoring. For example, thyroid surgery, recurrent laryngeal nerve palsy is a known risk. So when to use? Still many surgeons don't use it. So it's essentially at present surgeon's discretion. So there is no medico-legal law that says that neuromonitoring has to be used. So that is one thing to consider. Surgeon's expertise, past experiences, the patient's current neurological status and expectations, and the availability of neuromonitoring under other practical considerations like a permissive anesthesia team and past experience with IONM. So for IONM to work well, anesthesia has to be very precise. So that's why it's a teamwork. So the surgeon, the anesthetist, and the neurophysiologist have to work together. If I'm taking too much time, please stop me. So whole range of surgeries get benefited from IONM. So brain surgeries, peripheral nerve surgeries. We have worked with plastic surgeons, spine surgeries, ENT surgeries, and even cardiothoracic surgeries. So the role of neurophysiologist is to decide what modalities are to be used. So whole range of modalities are there. You can't use all these modalities for all cases. So we have to pick and choose as to what is to be used based on what is the structure at risk. So, and not only that, you choose 4 or 5 modalities, you don't look at them throughout the surgery. So in a particular step, if a particular structure is at risk, we shift the focus to that particular modality. So what is the role? We have to ensure that we get good quality signals, and we have to understand the electrical properties of the OR, and we have to know how various anesthetic agents are affecting the signals, and we have to be really good at the instrumentation part, and we have to understand how the other systemic factors affect these signals. So that's the major challenge. So it's like solving a puzzle. So once we get these signals, we have to identify changes in the IONM data and recognize significant changes from non-significant changes and interpret these changes as to whether they are surgical or anesthetic or systemic, and we have to propose interventions to change. Our job is not to force the surgeon. So we just pick up the changes and inform the surgeon's response that matters as to whether they can wait or whether they can actually change the surgical goal. Okay, let me stop the resection here. So that's surgeon's response. So these alarm criteria as to what is considered as a significant change is not fixed in the literature. So we say that if there is a 50% drop in signal or a 10% change in latency, that's considered significant, but it's not so. It varies on a case-to-case basis. So there is a lot of context dependency with respect to alarm criteria, and that's where experience matters. And our whole job is to raise an alarm and make sure that every time we raise an alarm, it's only a true alarm and not give false alerts. So if I give a lot of false positives, what it means is that if I say there is a change, there is a change, there is a change, the surgeon will start undercorrecting. Okay, and if I don't raise an alarm at all, it becomes a false negative, then that's like worst case scenario. So I say everything is all right. Surgeon trusts that, and then the patient ends up with a deficit. So that's the worst kind of scenario. So that shouldn't happen. So this is how signals look. So this is a true change. So you can see that there are control signals.
Nobody can see what to explain.
Okay, just so these are control signals. This is there on both the screenshots. So no change here. Whereas with respect to remaining signals, this green has become flat. The red is still there. Okay, this is baseline. This is after a critical step. So that means it's a true change. Contrast it with this particular data where the control signals have also become flat. So what is the control? If I'm doing a lower spine surgery, upper limb muscles are controlled. So if a drop happens and if the upper limbs have also dropped, it's not plausible that it's due to the surgical insult. Therefore, it should be due to other factors. So that's why we always have a control. And this is a testament to what I said. So here there is a drop, signal is there, flat, and then signal starts appearing. So this is proof of reversibility.
So for everybody, this is exactly what he sees in the such tiny graphs, and he has to make a computational analysis whether the drop is significant or not. So this is his job when he is doing behind the curtain all the intricacies.
And this is the fine rope on which I kind of walk to actually convince some big giants, neurosurgical giants.
I'm the only one who listens now.
Right? So there are many causes of false positives and false negatives. We have to rule them out. So I've made a sneak peek. So this is for motor mapping. So this is called phase reversal. You can see waveforms going up on specific channels, down on specific channels, and wherever there is a phase reversal, that's where the central sulcus is. So that is very useful in identifying what is a motor cortex, where is motor cortex and where is sensory cortex. And then we map, this is the hand area, this is the leg area, like that we map based on where we get the responses from. And then we also do what is called subcortical motor mapping. So corona radiata, we all remember from our neuroanatomy. So the tumor is not just sitting on the surface. As you go to the depth, you have to make sure that you are away from the those important tracks. We monitor the eighth nerve through what is called brainstem auditory evoked potential. We have series of waves, wave 1 to wave 7. Wave 5 is the most important wave. And they are also used as a surrogate for brainstem functions. So they are called brainstem auditory evoked potential. Because of the tumor resection.
Go back one second.
Yeah.
So this is what we get to see when we have opened the dura. So there is no way for us to know which is the sensory cortex, which is the motor cortex. So that is where the challenge is. If the tumor is inside the motor cortex or close to the sensory cortex, unless we know which area is the motor cortex, we can't approach from that tab. That is where he comes and tells us, gives us the right direction that this exactly is the place you should not enter.
Surgeons have their own surgical principles as to how to identify sensory motor cortex. But when there are big tumors causing lot of distortion, even experienced surgeons get, kind of bamboozled. So these are like direct recordings from the spinal cord, and this is what is called a bulbocavernous reflex. One of the beautiful things about electrophysiology is that we assess reflexes, deep tendon reflex. There is something called bulbocavernous reflex, which is assess to see whether the patient is continent or not. So basically we give a tug to a Foley's catheter if the patient is catheterized, or a pinch over the dorsum of penis, and look at the contraction of the anal sphincter. So the same thing can be electrically recorded if you have good electrophysiology tools. So that's what bulbocavernous reflex is. And during resection of conus cauda tumors, we make sure that this reflex is intact throughout, so that the patient doesn't end up with incontinence issues after resection. This is a very common complication, like childhood spinal dystrophism surgeries. Post surgery, child becomes incontinent. So very common prior to era of intraoperative monitoring. Now, in our center, we don't see it at all. So this is for lower cranial nerve monitoring. This is called 3-4-6 monitoring. We place electrodes on the extraocular muscles, and this is for epilepsy surgeries. So you see spikes on the surface of the brain and within the substance of the brain, and we have to guide the surgeon as to whether the resection is making meaningful changes to these patterns, so that the epilepsy surgery becomes successful. And then this is a specialized response called lateral spread response for hemifacial spasm. I'll show that in a video. How much time I've got? Accordingly, I'll show some clinical data. Okay. So this is motor mapping case. Okay. We get these kind of signals, and so these are spikes because of stimulation. So we stimulate the brain, that itself can cause a seizure. So these spikes, if we see, we stop the stimulation and pour what is called cold saline, so that it doesn't progress into a frank seizure, right? So these are those after discharges, and we pour cold saline and then they go off. So this is like, and then as the surgeon is operating, we look at the corticospinal tracts. This is the current value. The intensity of current gives a rough estimate of how much distance they are away from the functional structures. And so that gives them an idea as to how much they can resect more. Right? These are interesting videos. These are like speech mapping videos. So we are doing a speech task, awake craniotomy. We are showing some objects, and there is a complete speech arrest. So he says, I'm not able to tell. Unfortunately, volume is not full. Okay. Okay. So this is a case of anomia. So we are showing objects. So it was a drum. So he is saying this is and then gesticulating and not telling the name alone. So that's the area to name, and this was the area for complete speech output. So this is another example.
January, February, March, April,
So these are all neologisms. So when I started stimulating, there was a complete pause, and then we stopped because we identified, but still the functions are not returning to normal. So she is making up her own words. So we are producing transient lesions during surgery and assessing their functions. How do we produce transient lesions? By interrupting the neural networks through current. So this is another example which will illustrate better. Yes. So surgeon is holding the probe, we stimulate. So this means something else. So this means there is a articulatory arrest, which means we are stimulating the area for the vocal cords. So that's why now she is able to make sounds, but sounds are not coming. I mean, the words are not coming. So another case, speech arrest, no speech arrest. Speech arrest.
January, February, March, April.
Speech arrest.
February, March, April, May, June, July, August.
So this phenomena means a particular area is being stimulated, which is the Broca's area.
January, February, March, April, May, June, July, August, September, October, November.
This is not complete speech arrest, these are paraphasias. So these kind of phenomenology we see. So if you see, the patient was not at all sedated. I mean, there was no drowsiness. So all thanks to the anesthesia team, because you need to have patients wide awake to actually carry out all these procedures. So this is another young executive with tumor on the frontal lobe. So we are doing what is called cognitive mapping. So it is not just to preserve sensory motor functions. So you have to preserve their memory, their personality, their decision making. So that is one step further. So this is basically working memory task.
0, 5, 9, 2. Good.
So he was a manager making lot of financial decisions. So we wanted to make sure his cognition is preserved. So he's doing a computerized task. So laptop is there on his lap, and then he's doing a task. It's called a block tapping task, and he has to tap the blocks in the same sequence in which they appear. So if they are intact, that means his executive functions are intact. So this is another task for decision making, where he has to inflate a virtual balloon. So he doesn't know when it's going to burst, and if he keeps on inflating, he will lose all the money that he has earned. So basically that kind of a game, and he plays this game, and we make sure that he doesn't make risky or rash decisions based on this particular task. So we have done cognitive mapping also, and then these are like cranial nerve monitoring. Like a similar principle is used for parotid surgeries for preservation of facial nerve. So whenever nerve is stretched, we get these kind of signals. So we recognize the pattern and inform. Many times, many changes are not relevant. So our job is to distinguish which pattern is associated with higher risk of injury and which is not. Right? So there are ways to identify fifth nerve and seventh nerve. This is the response of the seventh nerve. This is the response of the fifth nerve. So not much of difference, but there are certain principles which we have to follow to identify the differences. Right? So I mean, I will just walk through without getting into the details because we have limited time. So this is for tumors close to the lower cranial nerves. The 9th nerve, 10th nerve, 11th nerve, 12th nerve. So we place electrodes in the vocal cords through the endotracheal tube on the soft palate and things like that. So this is how we place the electrodes. This was a live surgery in Ames, Patna, and that's how I had a video. Otherwise, I don't take videos. And this is a novel reflex called laryngeal adductor reflex, which measures the uh, um, vocal cord response, the sensory information from the vocal cord, which actually predicts the need for prolonged intubation. So we have started doing this also. And these are other potentials: spinal cord mapping, the conus cauda surgeries. So one thing I want to mention is that mostly neuromonitoring is only limb saving or nerve saving, but there is a very special scenario where it becomes life saving. One such scenario is babies with congenital or malformations detected in utero. So the mothers have to make a decision as to whether they'll go ahead with the pregnancy and give birth to a child who has spinal cord malformation, or whether to terminate. Right. So one such collaboration was with the fetal medicine expert, Dr. Manikandan, who's not alive now. So he recently passed away. So we've been doing it as a program for the last 5 years, and we have done about 20 babies. So where these babies are detected in utero, we counsel them antenatally, and they come here to get delivered, because if it is an open spinal malformation, it is prone to infection. So they cannot get the baby delivered outside. So they come here, get delivered, and then we do this surgery on day 2. So that's our earliest. And on day 2, it's very challenging to do intra-op monitoring. The nervous system is not mature. Anesthesia is even more complex. And we have successfully managed to do. And yeah, so this is what we see post-surgery. So if the baby is moving, then that's a great sign. Right? Yeah. So this is Vishwaraj's case. This is the lateral spread response. So you have this patient constantly twitching. So this is because of an aberrant vessel that sits on the facial nerve. So you will have to identify which is that aberrant vessel. So this patient was guided by what was called lateral spread response, and the aberrant vessel was not obvious in this particular patient. So the response vanished about 3 times with respect to 3 different locations, and finally we found the exact site. So it helps to navigate and identify those kind of abnormal structures. And some work outside the, okay, I'll go to this particular slide. So how neuromonitoring has transformed practice at SIMS. We do about 250 cases, and we do about 10 conference presentations, not just me, our whole team. So we are invited to talk about intraoperative monitoring's impact, and we host multiple workshops and live surgeries, and we have 2 DNB students doing thesis on intraop neuromonitoring. And we also have trainees, the first trainees in the UK, and this is just publications the last year alone, and this is in the latest year. And I'm also part of the international working group, which actually publishes guidelines as to how studies have to be reported. And if you see, uh, all top centers, and I'm the only one from Asia. If I don't tell it, nobody would know. So these are all who's who of neurophysiologists. The one who's very old is Professor Nuwer. It's his textbook that we followed and still follow. So this was like a Delphi process where we sit and kind of make recommendations. And outside the OT, we get some lab evaluation also. So we do electrodiagnosis. Whenever patients comes with neurological symptoms, we do testing, and we help in localizing and typing the kind of neural problem and assess severity and chronicity through various studies. And these are some of the common referrals, complex cases that we get. And electromyography is not easy. You need to do a lot of self trials. So it's not just putting a needle. So, and we do autonomic evaluation also. So many patients with POTS we have diagnosed in the laboratory. You can see that the heart rate is about 50s or 60s, and as soon as the patient stands up, it goes to about 120. So the heart rate rise is more than 30 from lying to standing. It's considered as POTS. So we also do tilt table testing for syncope evaluation. So this was a recent patient in whom we did drug challenge test also, and the patient had an asystole of about 10 to 15 seconds, and we duly referred to Dr. Sanjay for any pacemaker need. So intraoperative neuromonitoring or clinical neurophysiology for that matter is like jazz music, where you don't actually have a plan. So you go there, see what's happening, how the surgeon is approaching a particular tumor, and then we have to kind of improvise. So in jazz, when there is a play, you have to play along. The point is not to actually over smart. So if you over smart, the performance of the band goes down. So we have to have that kind of a mindset. And yeah, clinical neurophysiology can be game changing for any neuroscience center for excellence. So with that, I conclude. Thank you.
Have you got any literature or work done on gene surgery? Because that is the most dreaded surgery for any manufacturer because of the proximity of the facial nerve.
Facial nerve. No, only you have to call us for facial nerve monitoring. We do parotid surgeries like facial nerve monitoring. The principle is the same, but yeah, we just have to start using it. I mean, we have to start from what is your experience with respect to complications? Like, have you seen paralysis happening? Then we can definitely consider.
So this is why we call him professor, because most of the things he says stays there for us for 5 minutes and then disappears. So thank you so much, Nishanth.